reinfarctions. Earlier, the intracranial hemorrhage incidence was higher in pharmacoinvasive approach because tenecteplase was used. But when in the elderly patients above 75 years, when the dose was reduced to half, the bleeding events were more or less balanced. So now the stream trial has shown that the pharmacoinvasive approach, if used judiciously, is not only efficacious but also equivalently safe. And this is not only seen in randomized controlled trials, the data is also available with a real world evidence. This is a Canadian Vital Heart Response Registry. It also shows a similar kind of. They showed that the pharmacoinvasive approach was somewhat better to primary PCI if there is a delay in primary PCI, and the bleeding events, intracranial hemorrhages, were more or less similar to primary PCI arm. An observational study from Indian subjects is also available and shows a similar data. So that means pharmacoinvasive approach is a suitable alternative if primary PCI is not possible in timely fashion. But whom to offer the pharmacoinvasive approach? It actually depends upon. This is a guideline algorithm developed by this Chandrasekhar et al. And published recently. And they suggested, gave them some indications that it will depend upon whether or not primary PCI capable facility is available and what time patient has presented. If the patient presents to a PCI capable center and PCI can be done within 90 minutes, primary PCI should be the norm. And if there is a delay, or if the patient present delay more than 90 minutes at a PCI capable center, or if the patient uh, comes to a PCI non-capable center where thrombolysis is available, and the transfer to PCI capable center takes more than 30 minutes. It's better to thrombolize the patient and then shift the patient to a PCI capable center. So in nutshell, primary PCI remains a gold standard strategy, but pharmacoinvasive is a suitable alternative, being an affordable, widely available, easily acceptable to patients. Patient can easily comprehend, because with us, money is a big problem, and it has got comparable results in terms of CV endpoints. And because there is increased bleeding with tenecteplase, we have to remember that you have to reduce the dose of thrombolytics, especially in elderly. And those patient trials which showed the effectiveness in pharmacoinvasive, they utilized tenecteplase and alteplase, but the streptokinase remains to be the most commonly utilized drug in us. So somehow we have to switch to tenecteplase and alteplase if you want to use the pharmacoinvasive approach. Now coming to second dilemma, what to do about the thrombus. ST elevation MI, we know that it's a thrombus-rich environment. Every often now and then we encounter a large burden of thrombus. This is an example. A patient, 60-year-old diabetic, came to us with inferior wall MI within 8 hours. We took him for primary PCI. Wiring was done. There was a flow. We thought thrombosuction is not needed because guidelines say so. We low pressure dilatation was done with two balloon, and after the next exchange, you can see a large chunk of thrombus migrating distally, and it occluded PD and PLV. CA with chest pain, patient became unstable. We were able to save the patient with bailout thrombosuction. So what does the evidence tell us about thrombus aspiration? Should we do it or should we not do it? The earliest evidence comes from a single center trial that was TAPUS. It was a small scale study, but it showed that there is improved perfusion and clinical outcomes as compared to a conventional PCI. But later on, when larger multi-center trials were done, which involved thousands of patients and were randomized trials, they showed that no, it doesn't show any improvement in clinical endpoints like death or EMI, shock, or heart failures. Even at 30 days or even for longer follow-up, 180 days, there was no improvement. And there was a concern of increased risk of strokes in patients who underwent thrombus aspiration. So somehow the earlier promising results of TAPUS were never replicated even further. Even the meta-analysis also show that angiographically you might obtain some better results, but clinically you don't get any significant benefits, whether deaths or EMIs or heart failures or shocks, and stroke remains to be higher in thrombus aspiration patients. So all the guidelines now say that routine thrombosuction in primary PCI cases should not be done. But bailout strategy, that means if there is a large thrombus burden, you can have a selective thrombus aspiration, or if you cannot do anything else, you can have a bailout. They give it class 2B because you do not gain any clinical end. That's why class 2B. But does that mean you can get away with the thrombosuction? You should not put any thrombus aspiration devices in your cath lab. What I believe is each and every cath lab which deals with primary PCI or acute patients should have a thrombus aspiration catheter inside their lab. every now often and then encounter these kind of patients where there are large arteries, ectatic arteries, large linear thrombosis, and you cannot get away with these thrombosis just by dilating these. And when you do a thrombus, you can see these linear serpiginous thrombus. And you get gratifying results without any slow flow. Even in some patients where you don't want to use, but sometimes you have to bail out the patient. This patient presented with anterior wall MI. We did a wiring, direct stenting. You can see cheesing of thrombus into distal LAD as well as OM. Patient starts complaining of pain. You have to suck it out of this using a thrombus aspiration device. So bailout sometimes and most of the times work. So it is my message is it is better to be between the two extremes, thrombosuction for all or thrombosuction for none. You have to be somewhere between. You have to apply some judicious uses of thrombus aspiration. Rational approach is better. You will get better final TME3 flows, but these are not a guarantee of better bilateral blush or improved CV outcomes. You will definitely better final angiographic results. You can go home, sleep peacefully with the satisfaction that you did a fine job. There are certain best practices you might adopt so that thrombus aspiration results are better. That means you start thrombus aspiration much before the lesion. You approach the lesions gradually, slowly with slow packing movements. You don't push the thrombus with any balloon or thrombus aspiration. Otherwise, there will be distal embolization. All the benefits will be lost. And suction should be off only when your tip of the thrombus catheter has been out of Y connector. Guide should always should be checked that it is engaged while you are taking the aspiration catheter out of the artery, and there should be liberal backbleed whenever after each and every run of thrombus. Now coming to another dilemma, defer stenting. What is defer stenting? You don't stent the artery immediately. You do a check angio, do something. You find a large burden. You may do some kind of thrombosuction, but you think that now if I put a stent, there will be a no flow or slow flow. You defer the stenting for a few days. Meanwhile, you do anticoagulants, GPTB3 inhibitors, or IV heparins, and you expect that the results will be better. You can come back after a few days and check. So this is nothing but another strategy to deal with a large thrombus. So thrombus aspiration we discussed. Now we are going to discuss deferred stenting. This concept was actually initially tested in the first TEMI trial. It showed that you can get better angiographic results. 6 months MRI showed that you will get smaller infarct size in patients who were deferred, and myocardial salvage index was better in deferred stenting patients. This concept was tested further in a large randomized controlled trial that was a Dynami 3,000 patients multi-center trial. They could not replicate the results. They showed that the angiographic results were better, but somehow this did not result in any clinical endpoint result. That means deaths were more or less similar, whether or you differ or not. So there was no, and this was all at the cost of higher chances of unplanned revascularization, re-MIs in between the waiting period. That means vessel gets occluded and you have to rush patient to the cath lab again, and uh, you have to do the rest PCI. Meta-analysis also tell you the same. Angiographic results are better, but clinical endpoints are not better. In summary, if you differ, you can deal away with the uh, high thrombus burden. At the end of the defer period, you get low thrombus burden, decreased procedural MIs, low incidence of slow flow and no low flow. So because the vessel has now grown up, you can take a larger stent, less chances of late delayed stent malapposition, smaller infarct size, and sometimes you can get away without putting any stents because there was only a thrombus, no residual lesion. But there are certain disadvantages. Unplanned revascularizations are high. This is a simplified algorithm we published in European Cardiology Review. Before you adopt to defer strategy, it is mandatory that you must have a TME2 or 3 flow. If there is a less than TME2 or 3 flow, you have to do some kind of intervention, which is called MIMI, minimally invasive mechanical intervention. You do some kind of thrombosuction or low pressure balloon dilatation, achieve some lumen, increase the blood flow, and then you give the patient some time, uh, uh, 2 to 4 days, 5 days. Meanwhile, you give GP2B3 inhibitors. Sometimes you just give heparins, or you can give intracoronary tenecteplase thrombolytic agents as well. And after some days, you come back, there is a reduced thrombus burden, you stent it. If there is a residual lesion, if there is no residual lesion, just be happy and continue the on DAPT. Now coming to second last dilemma, that is the multi-vessel disease almost half of your patients who come to you with ST elevation MI will have multivessel disease, non-infarct related artery, will have significant stenosis in them. So this patient, 68-year-old male, PCI2RC was done in past, now comes with anterior wall MI. Along with LAD lesion, there is a circumflex CTO and there is a significant ISR in RC. What to do with these for these patients? Two strategies can be done. Either you deal only the culprit artery and deal the rest vessels later on, or you go for the complete. Each of these strategies have got certain pros and cons. Culprit lesion only, it will be a short procedure, lesser complications, lesser cost. Your customer, your patient will be satisfied customer. But if you choose to go with the complete revascularization, increase procedural complications, increase cost, and also the risk of being labeled as an irrational implanter by your fellows. So what does the evidence tell you? Are these, if any of these strategies is better than the other? These were tested in PRAMI, Civil Print, Dynamic 3, Compare Acute and Complete. A large number of trials, some of them adopted to angiographic stenosis severity. Some of them saw whether it is FFR, they assess the significance by FFR. Some of them were adopted to both of these techniques, and they were followed up for variable duration of time. They assessed FMIs, and in fact, revascularization, all of them were positive trials. That means complete revascularization was unanimously better than complete lesion only. I will not talk about each one of them, but I will talk about complete, which is the largest and latest of these trials. They randomized 4,000 patients into complete and culprit lesion only. There were two primary endpoints, CV death or MIs as a first primary co-primary endpoint, and the second was CV death MI and ischemia revascular. Both were significantly reduced in complete revascularization arm, and all of them were predominantly because of reduction in MIs and ischemia-driven revascularization. There was no change in incidence of death. So by doing a complete revascularization, you are only reducing the future MIs and ischemia-driven revascularizations. Why? How does this benefit happens? Or if you don't do the complete revascularization, why the prognosis is poor? Because it has been seen that those occlusive non-infarct related arteries, they have got a higher incidence of TCFAs, the thin cap fibroadeenomas, which are known to be vulnerable plaques, and this is a mechanism which ruptures and causes the re-MIs in future. So 50% of these non-infarct related arteries have got TCFAs, and that's how you achieve the benefit. FFR guided approach was used in Compare Acute and Dynamic 3. They also showed that the complete revascularization was better as compared to complete culprit only. And the Flower MI, which compared whether you should go for a visual guidance only or FFR guidance only to decide upon which arteries to be revascularized. It showed that whether you assess the significance through angiographically or FFR guided, both of the techniques are more or less similar, and the end results are similar. That means you have to aim for complete revascularization, whatever the strategy you utilize. Similar is was seen in meta-analysis by Bene et al. Now coming to timing of procedure, should you do at the time of primary PCI or you can stage it, same or stage before the discharge, more or less similar endpoints. You can see all of them favoring that the multivessel PCI was better. And same and staged, it doesn't make a difference. So if it is a short and sweet lesion, you can do at the same time. Complex lesion, you can stage it after some time. What about, should it, this complete revascularization, these results should be valid only for primary PCI patient or this other arm, that is the pharmacoinvasive PCI? Because as I discussed, pharmacoinvasive is a sweet alternative to primary PCI patients. This answer can be reflected in complete trial pre-specified analysis, though the sample size will become even smaller. But since it was a pre-specified analysis, this message can be taken home that if your patient comes after thrombolysis, and if you take him for angiography, you find a TBD, you not only treat the infarct-related artery, you can treat the non-infarct-related arteries as well if they are clinically significant. So summary, if possible, complete revascularization should be the target. Patient goes happy without any fear, and be sure of no angina on immediate follow-up. But you must know in your heart that there is no benefit in terms of death, and you are just reducing the future ischemia-driven PCIs. Those who prefer culprit-only PCIs will always have an opportunity to evaluate the ischemia on follow-up. No comparison of these two strategies is available. That means you can go upfront with the complete revascularization or ischemia-driven. These strategies yet to be tested. So if somebody follow up a different kind of a strategy, that is the ischemia-guided strategy, he's right in his approach, and they can continue to do so. Now coming to, what if the same patient, a multivessel disease patient, was in cardiogenic shock? What will you do? You will just treat the culprit lesion only, or you will revascularize the other tight lesions? The common sense says that if you revascularize the other tight lesions, probably the myocardial pump will start functioning better and the inotrope requirement or cardiogenic shock will improve. But some, we know that the most of the times your common sense may fool you and may get you to burn your hands. This answer was seen in culprit shock trial. It showed that if you do only culprit vessel PCI in shock patients, you will be better off rather than you deal with the multi-vessel PCI. There will be more chances of death or renal replacements in multi-vessel PCI arm, and this was predominantly driven by increased number of deaths. So it is better to stick to culprit lesion only. So the guidelines on revascularization also say that it is a complete no-no. Complete revascularization is a no-no in patients with shock. Stick to complete culprit lesions only. Now the last dilemma, late presenters. In our country, we often see patients who come to us after 48 hours, 3 days, 5 days, 7 days, or even they receive some kind of thrombolysis. They come to us after a week. They are now symptomatically stable. You do an angio, but you find a artery occluded. What to do? So this was a patient, inferior wall MI, left dominant system, proximal circumflex occluded, hemodynamic stable. If the patient was having some angina or some kind of clinical instability, it was a different ball game. You can go away and fix the artery. But if the patient doesn't have chest pain, BP is fine, no heart failure, nothing, no complication, what to do? So earlier we know from our pathological studies, we know that as soon as the artery is occluded, as the time passes by, the after golden period of 4 to 6 hours, the myocardial salvage remains very poor. At the end of 12 hours, there is minimal gain if you open up the arteries, and even less if you open up the arteries after 24 hours. So there is no benefit in patients if you open up the arteries later. But it is not so. There are certain there won't be any myocardium to salvage, but there are certain modifiers to myocardial salvage. That means if these are present, there are chances that the myocardium will survive longer in ischemic conditions. For example, if there is an antegrade flow due to spontaneous recanalizations, certain studies have shown that spontaneous recanalization can occur in 20 to 30% of the cases. That means artery was occluded, MI happened, and afterward there was a spontaneous recanalization, and there was some ischemic myocardium, it got recanalized, and there was viability. There may be collaterals that, and up to 30 to 40% patients develop collaterals, have shown collaterals in various different registries. So we know the collaterals can cause the myocardium to survive longer, decreased oxygen demand of myocardium because of ischemic preconditioning. These are certain modifiers which cause the myocardium to preserve or stay alive longer in the scenario of complete occlusions. So what happens if we open these arteries in late stages? This was tested in one of the famous trials, the O trial. They showed that if you open up arteries 3 to 20 days after MIs, what happens? They compared medical therapy versus PCI with stenting. They showed that the PCI did not reduce any cumulative endpoint. There was no reduction in deaths, MIs, and heart failures. In fact, there was increased chances of reinfarctions. But I must inform, that means after 24 hours, you should not open any artery. But I must remind you that there were certain exclusions in this study: heart failure, shock, creatinine more than 2.5, significant left main, triple vessel disease, angina at rest, and severe ischemia and stress testing. These were the patients who were excluded. So that means OAT findings cannot be applied to patients who have these findings. So not all patients who present to you late will fare better on medical therapy. And apart from OAT, there are certain small scale studies which have shown that if you revascularize beyond 12 to 24 hours, you might gain some benefit. Brave 2 study showed that if you revascularize 12 to 48 hours, patients who come for 12 to 48 hours, infarct size will be smaller. The 4-year follow-up study showed that it will predict improved mortality if the patients receive delayed PCI as well. So that means myocardium was viable even beyond the stipulated period of 24 hours. a study which was published in 2018, which compared patients who presented within 12 hours to those presented 12 to 72 hours. We saw that if we see revascularize this patient, what would be the myocardial salvage index? There was a significant myocardial salvage index in both the groups, and the p-value was not significant. That means both the patients derived similar kind of benefit if they underwent PCI, whether the patient presented within 12 hours or 12 to 72 hours. Meta-analysis done by Abart et al. Also showed that these small-scale studies, if we combine BRAVE2, WCOPY, BOAT, CC, TOAT, and TOPS, that means delayed revascularization has got some benefits to offer. And this was usually in terms of repeat revascularizations. And this was not only repeat revascularizations, there was improvement in ejection fractions and LV sizes as well. Again, a similar study which showed short-term, not only short-term, but also long-term benefits in patients who were revascularized beyond in 12 to 48 hours. So now the guidelines, earlier guidelines used to say that you should not intervene in artery which has been occluded beyond 24 hours. Now that deadline has been increased to 48 hours. So asymptomatic stable patients, routine PCI in occluded IRA should not be done if an artery has been occluded for 48 hours in patients with ST elevation MI. But there is an important clause which we often miss, which ESC guidelines and ACC guidelines both highlight, is these patients should be managed like all patients with chronic total occlusions, in which revascularization should be considered in presence of symptoms or objective evidence of viability or ischemia and turbidity of occluded arteries. We published a small algorithm that if the patient presents late, you can go for a symptom-guided or an ischemia-driven approach. That means if the patient is symptomatic or hemodynamically unstable, you can open up the artery, or you can do an angiography and find out if the artery is flowing. Then you go for ischemia-driven approach. If the artery is occluded, you go for viability approach. If the artery is occluded, if there is a significant viability, moderate or a large area is under risk, you open up the artery. For smaller arteries, you may not derive any benefits. For open arteries, you go for ischemia-driven revascularization. If there is inducible ischemia, you open up arteries. If there is no inducible ischemia, leave them on medical management. So in the end, pharmacoinvasive approach is a comparable alternative as well as safe alternative to primary PCI, especially for us. Thrombus aspiration, it may not be suitable for all, but it does help some of the patients. Deferred stenting is a suitable alternative. It does offer better angiographic results only for stable and those with TB2 or 3 flow. Complete revascularization is always better than the complete revascularization. It reduces ischemia revascularization, and those who are latecomers beyond 48 hours revascularize only if there is evidence of viable and ischemic myocardium. Thank you so much.
Thank you, Dr. Pravesh. Any questions?
No, I think we should take up the question.
उनको वेट करना पड़ेगा ना?
हाँ, online. This being an online session, it's better to ask any question or put some comments on his talk right now. Otherwise, he'll have to keep waiting.
Dr. Pravesh, I have a question. How does you decide the viability after 12 hour or 24 hour?
We usually subject the patients to SPECT. Because SPECT actually, SPECT versus PET, what I believe is PET may be a gold standard for detecting viability. But PET actually can detect the patients who have got patchy viability. And those patchy viabilities, if you revascularize them, you may not get a clinically evident benefit. But if there is a large viable myocardium, which is in caecesium, there is a high chances that if you revascularize that patient, you will attain a benefit. So my best methodology to assess is SPECT. If the patient cannot afford, or if there is an opportunity, we go for dobutamine stress to see a dual response to dobutamine stress echo.
Would you recommend dobutamine stress in day 2 MI? I think we should.
Usually we don't do dobutamine stress because it becomes very subjective in these patients. Plus also there is a high risk of arrhythmias. So not very in early time, but if the patient comes to us in 6th or 7th day or 5th day, patient has been stable, then we can do.
What do you think? What is the role of MRI in such cases?
MRI is an excellent investigation, sir, but so far I have never seen any reports, whether done in SGPGI or in our department or in RML, that have reported consistently the viability. So we don't go for CMR.
Actually, we don't have very good MRI facility in our part of country, but in care hospital and in corporate hospital where good MRI facilities are available and cardiac radiologists are available, those who can interpret it.
I agree. I agree, sir.
Cardiac MRI
if CMR reporting is available, it can be done without wasting time. CMR would be one of the gold standard tests versus the viability. Because
thank you,
that
Dr.
can
Pravesh.
immediately tell you whether it is a scar or not.
Yeah. Thank you, Dr. Pravesh, for nice deliberation.
One question, Dr. Pravesh. Many times we see that patient after getting discharged, after 15 days or 1 month, then they go for angiography, angioplasty. Then what's the use? If he is having no ischemia and patient non-thrombolized. In RC, most commonly we'll see the doctor बाद में करवाएंगे angioplasty and they go for angioplasty and it has already been done without going for any stress test.
Agree, sir. This is a very pertinent question to our our part of world, where patients usually do not have the sentiments to grasp the seriousness of the disease. Most of the times, when they are stable, they go back to home and then arrange money and then come back, or they are not, even if you advise them. But if you look at the guidelines, any patient of ST elevation MI, they always develop some kind of regional wall motion abnormality. So any patient with a ACS with the regional wall motion abnormality or LV systolic dysfunction, they earn an angiogram. So angiogram should be done. It is when we talk about prognosis, we are not talking about only about infarct-related arteries. We have to understand the anatomy of these patients. Whether it is the only artery, are there other arteries involved? Was it a proximal artery? Was it what is a distal artery? Is it a left main equivalent? Whether there is a left main equivalent, because these are prognostically important information in these patients with LV systolic dysfunction. The patient doesn't have any systolic dysfunction, especially in small inferior wall infarcts or posterior wall infarct, we can get away. We can continue on medical management. I am sure these patients will fare well. But if the patient is diabetic, or if the patient has got anterior wall infarct, if you see signs of proximal infarct in RCA or circumflex or LED territory based on ECG, it is always better. What we advise is get an angiogram done, then we will decide whether you need an angiogram or not. Some angiography is really simple, and most of the times, you will believe me, son, they have got triple vessel disease, especially diabetic patients, elderly patients, and they will benefit from complete revascularization by going up bypass.
Thank you.
Thank you, Dr. Pravesh.
एक सेकंड बेटा
Thank you, Dr. Pravesh, for your nice talk. Now,
Wait,
the
रुको
next
एक मिनट।
topic is how to appraise the case of unstable angina and non-stable ST elevation MI in 2022. And the speaker is Dr. Akhil, Department of Cardiology, King George Medical University, Lucknow.
Good evening, all. First of all, many congratulations to Dr. Alok Singh to conducting this wonderful conference, and good evening to all the audiences who are present as physically or joining us as virtually. And today my job to talk about how to approach unstable angina or NST ACS in 2020-22. Definitely in last 2 years, nothing much changed in the management of the NSTMI. In 2020, we have the guideline from the ESC, and 2020-21, we have a guideline about the management of the chest pain in emergency from ACC-AHA, and some of the upgrade made in the management of these conditions, and I will just try to highlight the kind of the changes. As Dr. Vishkarma already point out the management of the STMI, we all aware that the STMI management little bit straightforward how we can manage the patient, but as presentation shown that there is an n number of dilemma how we can manage the kind of the patient. Again, when we come to the unstable angina or NSTMI patient, this is the patient population which is very benign presentation to the very malignant. The event rate in patient of the NSTMI may vary from less than 1% to more than 70% in first 30 days of the hospitalization. So this is the patient population which varies in presentation spectrum as well as their outcome. And to manage these kind of patients, we have to have opt a individualized therapy according to the patient in view of the different cardiovascular society guideline. Definitely, it's difficult to manage a tailored fit management strategy for each and every patient. But I will try to make one opinion about the management of these conditions. I will start my presentation with the case examples. Is my slide moving?
No, you'll have to share your. Now it is okay, sir.
Okay. So I will discuss my case. One is the 55-year-old hypertensive smoker man presented with the angina on effort with recurrent episode of the chest pain at rest in past. On regular treatment for NSTMI from last 6 months, now presented again with the chest pain and sweating, history of syncope followed by the chest pain 6 months back presented. ECG shows generalized STT changes which give us the prediction of the triple vessel disease, or we can say that the left main disease. HS troponin shown significant rise during at 1 hour or 3 hour of the investigation. Echo shown no RWMA, normal LVF, and we posted the patient of the CAG with thinking that the patient had a significant coronary artery disease due to the recurrent event in 6 months, angina at presentation, and patient also had the syncope as a presentation. And we did the angiogram, and this was the angiogram of this patient. Left system almost normal. Patient had somewhat disease here and there, but no critical stenosis identified. And when we go to the right system, it's again the had the proximal RC as minimal disease is the 30 to 40%. This is the RCA, which again has the proximal stenosis, but it's not critical between the. And second patient is the 65-year-old male diabetic hypertensive presented with the complaint of chest pain during the cycling 7-day back. Relief spontaneously, now presented with the angina on effort, on regular treatment for diabetic and hypertensive, well controlled, ECCOs, RBB without any significant change, eco normal, and HS troponin is also within the normal range. And because of the diabetes and comorbidities, we posted this patient for the CAG with the intent of the revascularization, and this was the angiogram. So he had triple vessel disease, almost all arteries had significant stenosis, long lesions, and multiple lesions, ostial and as well as the shaft and proximal and distal, all arteries are significantly diseased. So I just like to focus here that what the guidelines suggested us to approach every patient with their comorbidity, their presentation, their ECG finding, their troponin level, their risk score. All these things give us idea how we can manage the patient, but we have to have identified each and every patient, and we should opt a strategy to manage patient with tailor-made approach, not only the general approach for each and every patient. Sometimes just guideline give us the idea how we should manage our patient, but it's not always true for each and every patient. So my point is there, we should have minimum resistance, or I can say that we have minimum resistance for the CAG, diagnostic CAG in form of the invasive cardiography, and or it may be in form of the CT angiography, but we have to have prognosticate our each patient who presented with the troponin positive. And all the guideline again reinforce the same statement. So in 2020 ESC guideline for NSTMI and in 2021 guideline for the chest pain from the ESC, ACC and AHA,
what they told us how we can manage the patient of the ACS and STMI. So in 2022, 2020 guideline of ESC, they just removed the NSTMI from the literature. They just given them another name of the NST ACS. So it's just a change, not on. They also removed the atypical cardiac pain and just place the non-cardiac pain. Just rule out the dilemma in the diagnosis of cardiac origin of the chest pain. So when we come to the definition of ACS, it's always include the clinical presentation of patient, ECG finding, and the biomarkers. And whenever we have a patient who had the positive, or I can say that they're suggestive of typical cardiac history with the change in the ECG or evidence of the cardiomyocyte necrosis in form of the raised biomarker labeled as the NST ACS, and if their biomarker is normal, then we can label the patient as the unstable angina. Over the time, and as the cardiology grown, and we all know that the diagnosis of the coronary artery disease improve over the time, definitely NSTMI incidence is also increasing. And when we come to the developed economy or developed countries, the STEMI diagnosis is so inconsistently in decrease, and NSTEMI diagnosis increasing. And when we compare the patient of the 1995, where the NSTMI is only 1/3 patient, in 2015, it's grown up to more than 50% for the for all ACS diagnosis. And when use the early angiography less than 72 hours of the admission, it's increased from 9% to the 60% in 1995 to 2015, and PCI rate again increased from 12.5 to 67%. And these improvements ultimately lead to the reduction of the 6-month mortality from 17 to 17.2% to 6.3% in NST ACS patient. So how we should manage ACS patient? Definitely, first of all, diagnosis and evaluation of the patient is the most important aspect. We have to have detailed history. We have to have evaluate patient thoroughly, their clinical presentation, their comorbidities, the vitals, the prior history, the medication history, all are the important things. So just go over the detailed history. Patient should be evaluated with the EC should be done within the 10 minutes of the first medical contact, and after evaluation of the ECG history, assess for the vitals and send the troponin if we are suspecting the cardiac origin of the chest pain. If troponin is positive, we can opt any kind of the troponin strategy, which may be the 0 or 1 hour strategy, or 0 hour or 2 hour strategy, early rule in and rule out strategy according to ACS. And if not possible, then we can opt the 3 hours strategy, which already mentioned in 2014 guideline of the ACC AHA. And if the HS troponin is positive, I will discuss the 0 or 1 hour strategy and 0 and 2 hour strategy in coming slide. If troponin T is positive and it seems to be a cardiac origin, then we should go for the non-invasive or invasive strategy to stabilize our diagnosis of the NST ACS. And if we've identified the significant disease, this patient should be managed by the invasive, by the revascularization, or if there is a non-significant disease, then we can go for the medical management. So any patient who had the ECG changes or typical cardiac history, cardiac chest pain history, or equivalent to the chest pain, we have to assess patient troponin level. If it's significantly rise or significantly change after the 1 hour, then we should admit the patient in CCU according to their viral stable vitals, and then we risk categorization of the patient should be done and decide how we can manage the patient. So this is some this is a busy slide, but in summary, in any patient of the suspected MI, if patient is stable, no ST segment elevation, then we rule out the STMI and go for the NSTMI evaluation. Patient who had the shock or CPR, definitely immediately admit in ICU and manage accordingly. If patient didn't have any STMI or ST elevation, persistent ST elevation, vital are stable, no CPR is required out of the hospital, then go for the blood sampling at the
point of contact. So 0R is considered at a time of the contact with the medical facility. This is not related to the presentation or onset of the chest pain. So whenever patient contact to the medical facility, first sample should be withdrawn immediately, and this sample result should be out in less than 1 hour of the time. And at the time of the result is HS troponin T is normal, below the recommended limit, patient can be ruled out and discharged and sent to the home and further evaluate according to their risk profile. If this result is not confirmatory, then we can opt for the 1 hour repeat of the sample after the 1 hour. And again, the sample is negative, then we can rule out the patient, and the change is not significant. Again, we can rule out the patient and discharge and manage OPD basis. If patient had the significant high level of troponin or the change in the troponin is significant, then we diagnose as the NSTMI. Patient should be ruled in and hospitalized and managed according to their risk category. After all these 0R and 1R sample, and we could not identified or clear the diagnosis, then we can again go for the 3R sample and echocardiography. And if after the 3R sample we had the changes in the troponin, significant rise or fall in the troponin, again diagnosis of NSTMI level. If there is no change after the 3R of the sample, then we have to discharge patient, or we can observe the patient according to the risk profile of the patient. So when we are talking about the ACS, USA and NSTS patient, you can see that the patient who had the low risk MI at the index visit is only 0.3%. When intermediate risk patient has the 10% and high risk patient has the more than 65% of chance having the MI, and 30-day MACE less than 1% for the low risk patient, and it's more than 70% of the high risk patient. So it's the very different presentation of the different patient population, and we have to categorize this patient according to their risk profile, and we have to assign the management according to the risk profile. One important thing which changed our practice from 2013-14 guideline of the ESC and ACC. Now we have in 2013-14 the HS troponin just started to come in picture, and it's shown that they increase the diagnosis of USA patient in form of the NSTMI. But in 2020, it's again recommended as a class 1, and I can say that there is the biggest change in the in 2020 guideline. And HS troponin T, which measure the troponin level in the nanogram, which is more than 1,000 point better than the normal conservational troponin assay, and it's increased the diagnosis of NSTMI. The patient who labeled earlier as the unstable angina, these are the almost 22 to 24% of the patient who labeled now as a NSTMI patient. So this is the gray zone where we can say that this is the zone where the troponin blind population is found, which reduced by the high sensitivity troponin, and now we have only patient of the unstable angina or NSTMI. There is no troponin blind zone with the help of the HS troponin, and definitely we are much wiser to diagnose patient as the ACS in these kind of population. It's again had there some disadvantage. We diagnose more and more patient of the non-cardiac troponin elevation, which may lead to the misdiagnosis and mismanagement of these kind of patient population. But in typical presentation, ECG changes, this definitely improve our management of the patient. So whenever we consider a troponin, it's not always cardiac, or I can say that there's not always the non-ST elevation MI. It's maybe have the n number of causes. So whenever we are evaluating patient, there is the importance of the careful evaluation of history, vitals, past history, any medication history, or any other associated comorbidity history are important. Troponin can be raised with the tachyarrhythmia, heart failure, hypertension, critical illness like the shock sepsis, myocarditis, Takotsubo. We all are aware that the n number of conditions can lead to the troponemia in our patient. So we have to have much more cautious when we are evaluating the troponin, chest troponin levels in our cardiac patient. So what are the implications of high sensitivity troponin? As I earlier told that this had the higher negative predictive value for the MI patient, reduce the troponin blind interval for our acute ACS patient, result in 4% absolute and 20% relative increase in the detection of the MI, and are associated with the twofold increase in the detection of the type 2 MI. And what the level signify, definitely higher the level of troponin, greater likelihood of the cardiac aneurysm or MI, and which lead to the diagnosis of accurate diagnosis of the ACS and STMI patient. So what are the recommendations from the society for diagnosis? There is nothing much change from the earlier diagnosis. The changes came in the form of the HS troponin T, which given at the 0 whenever we contact the patient, and second simple should be given for the 1 hour in the 0 hour and 1 hour algorithm. If it's not possible for our center or it's not available, then we can go for the 0 hour or 2 hour algorithm, and these are the patient population where the troponin is recommended, HS troponin T is recommended as the class 1 indication. And again, the important thing is that none of the other biomarkers are recommended to diagnose or prognosticate the patient of the NSTMI ACS patient. Imaging, again, the change is significant change in the form of the class 1 indication of the CT coronary angiogram, which is almost equal to the invasive coronary angiogram in patient who had the low to intermediate likelihood of the CAD. So CT angio can be used left and right in patient who didn't have the very high or high risk characteristic at the time of the presentation. Patient monitoring patient of the NSTMI should be admitted in the CCU, monitored up to the 24-hour or till then the PCI done. If any patient who had the cardiac arrhythmia or hemodynamic instability, prolonged monitoring is recommended.
We are expecting,
sir,
we are expecting more of a summary with you. Running short of time, sir. Please don't mind, but you have you have to keep your time in mind.
Yeah. Okay. So next we come to the risk assessment. So the 2020 guideline recommend that we should follow the clinical decision pathway or GRACE score for more than 140 is recommended as the high risk. So we identify our patient who are the high risk or who had the low or intermediate risk profile. So whenever we come to the risk profile and how we should manage the kind of the patient, I will discuss in coming slide. And the second point is the anti-thrombotic treatment. What changed in the 2020 guideline? We have to mention both the ischemic as well as the thrombotic risk. We have to manage according to the individual risk score for the thrombosis as well as the ischemic event in future. So we have to balance both the risk, and we have to again have to choose the tailor-made approach for our patient, which antiplatelet therapy should be given, which anti-thrombotic agent should be given according to the bleeding risk score. So this is a diagram which shown that how we can manage our patient with the anti-thrombotic event in form of the unfractionated heparin, enoxaparin or bevalodidine, and how we can manage this patient with the low, high and very high risk according to their ischemic risk. And again, when we come to the patient of NSTMI with AF, I think is already discussed. In patient with the low ischemic risk, we can continue the therapy up to the 1 hour or 1 month or 3 months. And in high risk patient, we can change the in 1 week with the clopidogrel and NOAX. And definitely NOAX is the antithrombotic of choice for the NSTMI patient who required an oral anticoagulant in comparison to warfarin or acetone. We all are aware of how we can go for the antithrombotic. I already discussed. Antiplatelet therapy, definitely it's important that in ESC 2022, the prasugrel given the added advantage over the ticagrelol, and it's mentioned as the preferred therapy in comparison to ticagrelol to manage the kind of the patient. But in the ACC or AHA guideline, you can opt any of the prasugrel or the ticagrelol according to the SR React or Plato trial. Again, we come to the how we should go for the invasive or selective invasive strategy and how we can categorize our patient. As I already mentioned, that the patient of the very high risk, hemodynamically unstable patient, recurrent angina, life-threatening arrhythmias, mechanical complication, heart failure, ST segment in more than 6 leads. Should we go for the immediate invasive strategy of less than 2 hours? Patient with early invasive less than 24 hours, and patient who has the stable, they can electively go for the invasive other ischemic test or the angiogram or CT coronary angiography. So it's important that in patient of the NST-AMI, early invasive therapy could not going to reduce the all-cause mortality. Definitely MACE event is reduced in patient of the very high risk or high risk patient, not in the lower or low risk or intermediate risk patient. I already discussed that how we should opt for the very high risk patient less than 2 hours in early invasive for the high risk patient, and we can go the elective or selective invasive for the low risk or intermediate risk patient. I already mentioned that the ACM CT angio can be done for the all patient. Radial should be at route of the choice. That should be implanted. Complete revascularization stable patient can be done, but complicated or cardiogenic shock patient, complete revascularization is class 3 indication. And what new in ASC, I think I already discussed, and I'm coming in view of the time, I'm coming to summary. NST, ACS, wide range of the clinical presentation and risk profile. HS, troponin T, improve the prognosis as well as the diagnosis in patient of the troponin blind window. Early rule in or rule out strategy definitely give us to the identified patient early and reduce load in our emergency department. One size does not fit for all. Tailor-made approach should be the adopted, and use of the risk score for better prognosis and management of the patient in form of the GRACE score, bleeding score, or ischemic risk score to manage the patient for a long time. Thank you very much.
Thank you, Dr. Akhil, for your nice talk. Any question from the audience?
Or any comment? The house is open for the questions and comment. Both the speakers have given a very crisp summary and valuable talk.
Dr. Akhil, do you see any role of CT coronary angiography in risk stratification of chest pain in the chest pain evaluation?
And definitely, and recent trial very nicely pointed out the role of the CT angio in also in emergency patient, outdoor patient presented with the chest pain. And if we rule out this with the help of the CT angio, their prognostication and the management can be changed. So in patient who had the dilemma in the diagnosis, when we have the troponemia and we are not sure it's the cardiac origin, so CT angio can be helpful in these kind of the patient. And sometime even is the screening of the calcium score in chest pain patient also helpful to identify the patient of the non-cardiac or cardiac origin of the chest pain.
Any role of GP2B3 inhibitor?
Very good question, boss. And I think it's a obsolete therapy in the cardiology. Only we can use the GP2B3 inhibitor as a bailout therapy, and the routine use of these kind of the molecule is not recommended in view of the latest update of the antiplatelet therapy with the help of prasugrel and ticagrelor. So we can use this molecule only for the complicated patient, no flow, slow flow patient, or we anticipated that the post-procedure complication is high likelihood, then we can use this molecule, but there is no role of the GP2 inhibitor in routine practice.
Doctor
Akhil Sharma.
Dr. Akhil, it was a brilliant presentation. I just want to ask you one question. When you're doing an angiogram and you find that there is a lesion in the artery, but you suspect that it's a possibility it may be a spasm. So what do you do in those cases?
Actually, if I am suspecting that this culprit lesion is a spasm, then I will go for the all kind of the vasodilation. We can use the nicorandil, we can use the nitrates, we can use the adenosine, and then repeat the our angiosort. And if the findings are similar, definitely we can go for the acetylcholine changes. This can be a theoretical talk, but for clinical practice, I never use the acetylcholine or piperine to check our patient of the spasm. If after the deliberate use of the nitroglycerin, diltiazem or verapamil or adenosine. If the findings are same, I consider it as a narrowing, and if findings change, then we consider it a spasm of the artery.
Dr. Akhil, one question just regarding antiplatelet therapy. Now that we have ticagrelor and prasugrel to treat these patients, there was one trial that compared ticagrelor with prasugrel and found prasugrel to be a better. Does these guidelines include that part of that trial? Which one do you think is a more superior choice for you with regards to prasugrel or ticagrelor? Because prasugrel was shown in that trial to be a superior molecule to ticagrelor.
Definitely, and it's again a war between the Europe and US. When we come to the prasugrel, SR-REACT data is wonderful. Definitely, it's they are trying to stabilize the superiority over the enrollment of the more than 5,000 of the patient, but they shown this superiority over the 2,400 patient only after enrollment. So the data with the prasugrel is wonderful. Definitely, we have to again tailor-made approach of the antiplatelet therapy should be used. We can go for the ticagrelor, but whenever we are thinking that we need much more potent antiplatelet therapy, it's a prasugrel of the choice. And definitely, again, is the market which lead to the underuse of the prasugrel and overuse of the ticagrelor. And data of SR-REACT is definitely encouraging.
This session, and thank you for your deliberation. So now I request Professor Sanjay to give memento to Professor Deepak Gautam. Now I request Dr. Vikas Agrawal sir to give memento to Dr. Rajiv Gupta sir. Now I request Dr. Jigyasu Singh to give memento to Dr. Akhilesh Singh. Now I request Dr. Jiten to give memento to Dr. Nilesh. Now for the session 7, I am inviting the chairpersons, Dr. Arup Das Gupta, Dr. Jitendra, Dr. Dheeraj Kishore sir is here. In this session, please come on the desk. In this session, there will be 3 lectures. One lecture will be online from King George Medical University. My mentor, Professor Rishi Sethi, will speak on the emerging role of artificial intelligence in cardiac risk stratification. Over to Professor Rishi Sethi, sir.
I hope you all can hear me.
Yeah, we can hear you, sir.
Okay, so a very good evening to all of you, eminent chairpersons, eminent members of the panel, distinguished ladies and gentlemen present in the auditorium today, colleagues who are joining us online. First, let me start by expressing my deep sense of appreciation to what Dr. Alok and his team are doing with Heart India and Heart India Conclave consistently for last many, many years. And it's a fantastic job, and it's always a pleasure to interact, come over to Varanasi. But today, unfortunately, because of prior commitments in the city, I'm joining you virtually, but it's pleasure nonetheless. So, apart from the work of cardiology that consumes most of my time, I also happen to lead a school of international biodesign with the with the help of IIT Kanpur, and I tend to deal with different technologies. And in that respect and in that role, I have some interest in artificial intelligence, and especially in cardiovascular disease risk predictions and various other things about which we can talk some other time. But specifically sticking today to use of artificial intelligence in risk prediction of coronary artery, how can we use it? What are the different things that form the gamut? So many a times it's being used at terms like artificial intelligence, machine learning, deep neural networks, big data. These are the terms that are being used many a times in relation to healthcare, and we keep on hearing these terms, but we don't seem to have specific idea what these terms means. Of course, we don't need to go into details of many of these terms because we are acting physicians and not computer professionals. We should be knowing about these terms. But then as the world is changing, we should have some insight about what these words mean and how these are interacting with healthcare as we move on in the next decade or in the end part of this decade also. So artificial intelligence essentially means any technology that helps computers, to mimic a human behavior. For example, it's a very generic term, and many other advanced computing techniques are part of this compoundium of artificial intelligence. And it essentially means that you have to go from a point A to a point B. You have a problem and there's a solution, and how you can reach to the solution from the problem. What are the various pathways you can take depending upon various permutations and combinations, and to do it without the active interference of humans? Then that exactly is the part of the artificial intelligence computing. While machine learning is actually a subgroup, you can say, of artificial intelligence, where without explicitly being programmed, the machine can, by experience, by the again and again use the computer algorithms, can become smarter, and their ability to learn and to improve themselves without being explicitly programmed to do so. For example, if you use machine learning in imaging and you give a machine 10 x-rays of pneumothorax and let's say a 1000 normal x-rays, then it can try to predict the occurrence of pneumothorax in the next x-ray given to it. But if you give the machine, by going forward, and you use the same algorithm and you go forward, and let's say towards the end of 2 years, you give a computer 10,000 normal x-rays and 100 x-rays of pneumothorax, then its ability to predict occurrence of pneumothorax in the next x-ray that it sees improves much, much more as compared to the previous. The more data you feed into the machine, the more machine learning helps into making correct diagnosis and helping us. Deep learning is actually a form of, we can simplistically put it as deep learning is a form of a very complex and advanced form of multiple regression analysis that we do in our statistics, and we will come to deep neural networks later. So these are the various terms that are used, and we'll see how we can use these different terms into prediction of risk of cardiovascular events in a population-based study. So artificial intelligence is not a new term. It was coined in 1955 by John McCartney. Thereafter, in 1961, there were first industrial robots. In mid-1990s, we already had complex algorithms that combined artificial intelligence, deep neural networks, and machine learning, and produced, machine playing. Deep Blue was the computer that actually beat Gary Kasparov, the world chess champion at that point of time. That happened way back in 1997. In the 2000s and the 2010s and 14s, we are seeing Siri, Alexa, a lot of artificial intelligence that are crossing our path without our realizing every single day. And let's see how they interact with the healthcare, especially in prediction of cardiovascular disease. So artificial intelligence in healthcare can be used for disease diagnosis. It's used for digital consultations. It can be used to personalize the treatments. You give a machine a large number of data, and it can personalize the treatment to that particular patient. And something that is known as new upcoming specialty of medicine, that is personalized medicine or precision medicine, when you take into consideration patient's personal profile, his hemodynamic profile, his allergies, his genetic makeup, and then personalizing treatment based upon that particular person and not giving generalized guideline-based therapy to the entire community. That is the personalized treatment, and computers and AI can help us in deciding that personalized treatment or precision medicines algorithms. We can use artificial intelligence for analysis of health plans. We can use it for medical data management, for new drug developments. Robotic surgery is being used